Hello, everybody. Welcome to this webinar, which is titled Bridging the Divide, Understanding Cardiovascular Health Disparities in Urban and Rural Western Europe. My name is Professor Amitava Banerjee. I am Professor of Clinical Data Science at University College London, and I'm also a consultant cardiologist specialising in heart failure at University College London and Barts Health NHS Trusts in London. I've got a team of 3 accomplished experts from around Europe who will be helping me to explore this topic and to discuss its implications. I'm going to firstly welcome Professor Christiane Angermann. Christiane is a cardiologist, and she's Professor of Medicine and Cardiology and Head of Clinical Research in Cardiology at the Julius Maximilian University of Würzburg in Germany. Christiane, welcome.
Thank you very much for this introduction. I have a very long-standing interest in clinical and healthcare aspects of heart failure and cardiovascular disease, and I'm very glad to contribute our experience at this comprehensive heart failure center, which looks at prevention of heart failure and its complications. So we are in the middle of what is in the center of discussion here today, and I'm glad to contribute.
Thank you, Christiane. I'd like next to welcome Professor Nick Townsend. Nick is Professor of Public Health at University of Bristol in the United Kingdom.
Yeah, great. Thanks, everyone. So I'm a Professor of Public Health. I'm particularly a non-communicable disease epidemiologist. I really focus on the prevention and control of non-communicable diseases. Based at the University of Bristol, where I'm Director of the Health and Social Care section in the School of Policy Studies. I have particular interest in cardiovascular disease, obviously has the greatest burden globally. And I'm a member of the European Society of Cardiology Heart Health Institute and the Atlas Publication Committee, both of which are based in Brussels. And the Atlas programme collects epidemiological data across Europe from ESC member states focused on the burden of cardiovascular disease and also treatment approaches within member states.
I would like also to welcome Professor Johan Sundström. Johan is Professor of Epidemiology at Uppsala University in Sweden, and is also an honorary professor at the George Institute for Global Health in the University of New South Wales in Sydney in Australia. Johan, welcome.
Thank you, Ami. So I have a background in cohort epidemiology and mostly prevention and risk prediction. And hypertension is probably where I've done most of my work, but now transitions to mostly work with developing digital tools for clinical research and machine learning methods. I work 1 day a week as a cardiologist at Uppsala University Hospital, in addition to what you just said.
Thank you, Johan. Okay, so let's launch right in. I want to, first of all, tackle access to care. I mean, how significantly do variations in access to timely and effective cardiovascular care impact the differences in burden between rural and urban settings in Western Europe? Nick, in your work that you mentioned in the Atlas in Europe, would you be able to comment on this?
Yeah, thank you. So I think the first thing to say is that there's obviously great variations between rural settings and between urban settings. But generally, we obviously find within rural settings that they're, due to healthcare infrastructure, there's probably less specialized care in rural areas, which will lead to slower diagnosis and treatment. I think we also get issues with primary care density, so low primary care density in these types of areas. And we'll go and talk about it later on, but even introductions of things like telehealth and technological solutions, we often find less uptake in rural areas as well. But I think, to end on a positive note, I think we can also say that actually when we look in where we have localized public health management in rural areas, we actually can find really effective preventive services in small areas if they're well served by healthcare services.
Can I just drill a bit more when you talk about localized public health services? Are there countries that you feel we should be following in this regard in Western Europe?
Yeah, I would say so. Scandinavian countries, I think places like Norway and other Scandinavian countries generally do pretty well with these types of approaches.
Yeah.
Can I also add that some, I mean, some parts of, especially Scandinavia, northern parts of Scandinavia, the actual driving distances could be pretty long. So I think that also affects access to care to some extent. One of the senior fellows in my research group actually pinged Google Maps for distances from each, the center of each postal code to the nearest cardiological cath lab. And there were massive differences across Sweden with pretty long distances in the northernmost parts of the country and in the mountains. So that will also affect acute care to some extent. And that said, I agree with Nick that the primary care clinics tend to become like small hospitals in themselves in these rural areas, in some of the more remote areas.
Thank you. And in Germany, do you see the same issues, Christiane?
I believe that we see these issues across Western high-income countries to a variable extent. What I thought needed to be mentioned now is that rural patients tend to have lower educational attainment as well, poorer health literacy. That's in particular true to heart failure. It's very surprising if we interview patients what is heart failure, they would not necessarily know as well as maybe myocardial infarction. But there's also less food security and maybe higher costs for access. We have I looked this up, we have a recent study, although the data is sparse, on rural regions in Germany that systematically show higher MI related death rates in patients ages 65 plus compared with urban regions. And the interesting issue is that the higher mortality is primarily the results of a higher MI incidence in rural regions, while the case fatality by itself is largely similar. And this is it appears that in Germany, MI incidence and not case fatality drives the rural disadvantages. It may be different in other areas of Europe, but we seem to reach the patients pretty well, and the higher MI incidence points towards perhaps potential regional variation in the effectiveness of primary disease prevention. That's what I learned from this. I find that remarkable, and it's maybe unlike other European countries, and that may also have to do why Germany lags a little bit behind in longevity, perhaps due to cardiovascular disease, or mainly due to cardiovascular disease.
So that's fascinating. Thank you for that insight. The primary prevention is where you're saying we should put our focus, at least in the German context, if we're to improve some of these variations or disparities. Johan?
Yeah, so I would second that with what Christiane just said. So we did an analysis in the Swedeheart registry, which covers all coronary care units in Sweden, and we specifically looked at some disadvantaged groups like people with severe psychiatric disease, and we noted that all steps in the acute coronary care chain were similar for people with severe psychiatric disease and people without. But so we were worried that maybe we would underserve these vulnerable groups. But it turned out when it comes to acute care, it's hard to sort of withdraw treatment from people, right? So they get all the good care in the hospital, and then what we still couldn't manage changing from our few days with the patient in hospital, where there are smoking rates, for example, and all their other preventive measures, their all of their lifestyle habits. So I think it underscored what Christiane just said, that a lot of the differences between urban and rural areas would have to do with the primary prevention and the lifestyle habits of people.
Thank you, Johan. And luckily we've got a card-carrying public health expert with us as well. Now, Nick, does this tally then with your initial comment that local public health infrastructure is what's needed, or is this really pointing at primary care, or its corollary?
Yeah, I think there's a combination of two things. I think we'll go on to maybe discuss some of the environmental change and the focus on wider social determinants that policymakers and public health people should really be focusing on. But I think what's really interesting is when we look at the cardiovascular disease pathway, in a sense, we understand quite well the behavioral risk factors that lead to the medical risk factors, physiological risk factors that lead to cardiovascular events. And actually, we have good intervention, particularly at those kind of initial medical physiological risk factors. Is we have seen premature mortality come down over the last 20, 30 years in cardiovascular disease. We've had statins. We know we can deal with hypertension. We know we can deal with high blood glucose levels. But in order to tackle them in individuals, we need to diagnose them in individuals, and then need to adhere to those primary and secondary prevention approaches. And that's what we find in rural areas where they don't have good healthcare access. Is actually there's almost a hidden burden, and then we also don't get great adherence to medication or these prevention approaches when diagnosed or put on them. Taking it one step back, of course, with a broader kind of public health perspective, we should really be focusing on these behavioral risk factors and the wider social determinants that are causing them, and making change in these environments so that people follow the healthy behavioral risk factors or healthy behaviors that will prevent them going on to have cardiac events early in life.
You mentioned the social determinants of health, and that there have been data about the impact of different measures of social determinants of health for decades, whether in Sweden or Germany or in the UK, all of the countries on the screen at the moment. What specific actions, maybe Nick, you first, what can we do to address these factors effectively? Because we tend to be quicker as systems and even in our research to deal with the more acute treatments, but these are the really kind of knotty problems in our system, aren't they?
Yeah, completely. And I think, in many ways, it's understandable that there's greater investment in acute care than there has been in prevention. But I think, a lot of us would kind of subscribe to the belief that an ounce of prevention is worth a pound of cure. And if we're looking at these kind of wider social determinants, of course, we're thinking about promoting healthy behaviors. We're thinking about enhancing access to healthcare. But actually, we should be taking it one step back and thinking about improving socioeconomic conditions, removing poverty, increasing education and awareness, and some of these environmental things like access to healthy foods and other environmental factors. We've got to think about air quality, obviously a greater issue within urban environments, safe housing, safe spaces for people to be active in. We think about maybe community resources, so community health workers, social support networks, even think about cultural competence and cultural outreach, so that we're reaching and connecting with people that, to get them to understand and link to these healthcare approaches. And all of this takes what we might call a multi-sectoral or cross-sectoral approach. The departments for health and the health sector picks up the burden of ill health. The determinants of health lie outside of the health sector. And we need to get these sectors to work together to be part of the solution if we're really going to have an impact at those types of levels.
Thank you. Christiane, in your clinical practice, in your research, in your work, does that tally with what we need to do in the German context?
Well, I believe Germany is not a specific, we're all in the same boat, let's put it that way. Healthcare systems differ, investments in healthcare differs, and Germany is for sure a country that invests a lot and has a fantastic healthcare system. I believe the problems are very similar in principle, although the level of attainment of longevity may differ between, or does differ between, different European countries. I just would like to make one more point. It's not only the health system, it's not the access to prevention programs. It starts very early. It starts with life habits, with eating habits. Children learn while they are at school. And we have a special German situation, actually, with the eastern and the western part of Germany. And in fact, even more than 30 years after fusion of Eastern and Western German parts, there's still a difference in cardiovascular disease prevalence and mortality from CVD between Eastern and Western countries, counties, so parts of Germany. And that is probably the case because of lifestyle factors that transition from generation to generation. The differences converge now, but very slowly. And it makes one more point, that healthcare system, access to preventive programs, all very important, but the basic situation of living, of education, of modes of living that are that children learn from their parents. This is where we have to start, and this is also why changes take such a long time to materialize. Does this answer the point a little bit?
Yeah,
I mean,
yeah.
Regarding Germany, there's no other countries I'm aware of that have this situation, and I find this always very impressive illustration of the power of just living circumstances and traditions regarding our disease trajectories.
Thank you. I could argue some of what you're describing in the East versus West disparities in Germany sounds like our North versus South disparities in England, or between England, Scotland, and Wales. And that segues nicely into what are the disparities, if there are any, or the differences between different European countries in this rural-urban variation, and if there are differences, what's causing them? You know, do we have good data on this, Nick?
So I think data, particularly at that kind of level, isn't maybe as strong as it could be. I think comparable data going down to within country differences isn't as strong as it could be, and I think that's really an area we really should focus on, and particularly in utilizing those data to then feed back into both healthcare and prevention approaches. I think I'd make the point that we spend a lot of time with our global burden of disease studies and global comparisons and European comparisons, make a lot of country comparisons between countries, which are very ecological, whereas actually we see massive variation within countries themselves. We're talking here about comparing rural to urban. measures of rural and urban are really generally based on population density. They do vary slightly, but generally based on that. We can see massive differences in some of the things we talked about: socioeconomic measures, healthcare access, healthcare facilities, food deserts, food accessibility, things like that, between rural areas, rural communities within the same country. And so we really kind of need to think at that kind of level. And that starts with collecting data at these levels so that we can actually target both healthcare and preventive approaches.
So I participated in a study called the CARE-ME study, cardiac, renal, metabolic, maybe something like that, CAREME. And we in that project we pulled data from I think 11 different European countries, or maybe Canada was in there as well. And the quality of the data on healthcare performance indicators were really different between countries, and in some countries you were sort of the only data you could get was from one particular hospital system, socioeconomically sort of very different from the rest of the country. Some other countries like the UK and some Nordic countries, you could get data from the whole population, but maybe not all layers, maybe just primary care in the UK system, and maybe a lack of primary care data in the Scandinavian systems. So I think that's we need to work on that. Just what Nick said, we need to make sure that we have access to all those kinds of data, not just comparing countries, but also within countries. I'm a little bit optimistic about the Euro Heart quality of care registry. I'm not sure if you've talked about it before, but we're here to talk about Western Europe, and I think that initiative can actually start spreading at least the templates for what kinds of data we think are important to collect in terms of cardiac care. I'm guessing it'll start with acute cardiac care, but moving out into prevention as well. That's been the hardest in Sweden. We have a long tradition of more than 100 quality of care registries, and getting primary care, getting key performance indicators for primary care has been the hardest, because of course they don't just care for one disease. So that's data sorry, go on, Ami.
No. That's super helpful. In both the Swedish data, but also in the European data that you're aware of, do we have any evidence that you're aware of to say that the people who are high risk, we in our clinical practice, particularly in acute care, we often use scores to delineate who we should be focusing our care or our prevention on. Are those high risk individuals different in rural and urban contexts, or are they the same?
Yeah, that's a great question. I'm sure Nick and Christiane have more to say about this. I just, preparing for this, I try to look over what the reports that I knew of, and the NCD risk factor collaboration really did some work on urban-rural differences, and of course it's very different in developing countries and in Western Europe. In Western Europe, we have more obesity in rural areas, for example, whereas it's quite the opposite in a lot of other parts of the world, and we have a little bit less physical activity, more smoking in rural parts. That's at least the evidence that I could find. The PURE study, interestingly, showed a higher prevalence of hypertension in rural high-income countries, but similar awareness, treatment, and control rates of hypertension in urban versus rural settings, which I thought was sort of hopeful.
Yeah, thank you. Anything to add, Christiane, on this?
I believe these were again arguments directed at the importance of social determinants of health, and the social and community context, the economic stability of people tend to be different in rural and economic settings, and education access and quality regarding health education, but regarding also education as a whole. So developing reading and comprehending abilities will enable people, regardless whether in rural or in urban settings, to educate themselves, to gain information by themselves, and therefore exert better self-care, healthcare. So I believe what Johan said was again arguments for the importance of these factors beyond the particular healthcare systems, the structure of who is responsible for care. That's also important. So we come to believe that patients are looked after, and there's evidence from the literature, looked after by specialists, by cardiovascular specialists, may do better than if they looked after by primary care physicians in the first place. It just may be that triangulation of healthcare between patient and different HCPs may prolong the time and dilute the effect. So focused high specialty care is one thing, and general knowledge, adherence, and mobilization of the patient is the other issue. I mean, beyond the system, the situation in each country, this is a phenomenon which I think is generalizable.
Thank you. So, Nick, Christiane just mentioned some of the healthcare professional issues and constraints. Through your public health lens, how important are the digital health tools and ways of working to improve access to care and bridge some of the divide across rural and urban care?
Yeah, I think, enormously important. And I think if we're looking at the development of digital healthcare and these kind of data-driven technologies, I think actually they can be very cost effective if we're trying to progress towards universal health coverage to make it more accessible and affordable for everybody. Certainly virtual care and telehealth improve access to specialist care and even continuous care for individuals. Big focus on mobile health, which we have seen leads to better management in rural areas, both on self-care and knowledge, the things that Christiane was talking about. I think one of the really important things that we certainly haven't got right within the UK, something Johan was referring to, with the kind of data that we can use and these digital health records and the integration of those data into our health systems and services that improves an exchange of this type of information, so that we can really kind of join up services. We talk about the Internet of Things. We can connect and exchange data between measures of things like ECG monitoring, blood pressure, but also take it one step further with ongoing continuous care, so that we can really improve health literacy and improve self-care. Obviously, within that, we need to improve digital literacy, and we need the infrastructure as well. And sometimes that can be late getting to these rural areas. And if we're looking at what we need to be careful of, is that if we have a kind of real technological development within our health services and within countries, is that technological development doesn't happen a lot quicker in urban environments than in rural environments, because we might end up with a relative inequality even greater than we started with. We might get absolute improvements in both areas, but actually, if urban environments take up this technology and the data a lot quicker than rural ones, then actually we could even widen that slightly. So any focus on developing technology really has to focus on it being useful for those communities and individuals that we might perceive as underserved or less accessible than to the health services as they currently lie.
Thank you, Nick. Johan, earlier on in the conversation, you were describing the remoteness of certain parts of Sweden in terms of care. So I imagine that there's a lot of experience there in telehealth and in use of digital technologies, even before the COVID context. Have you got anything to add in this regard?
I think we learned, at least I learned a lot from COVID. So in my practice, I've transferred everyone who I don't specifically need to see and smell and feel. I just take care of them over telehealth. So I think there's a lot more we can do. I'd like to share one piece of hope. We in one of the clinical trials that we do, it's called Smartest. We challenge metformin with dapagliflozin as a first-line treatment for type 2 diabetes. we invented a digital consent tool so that we could, for the first time in Sweden at least, get people to consent to a randomized drug trial over video. And then we got a whole new set of patients into that trial compared to the people who are normally in clinical trials. So we had 30 people in Arvidsjaur, the northernmost part of Sweden, who never partake in clinical trials, who are now part of this study just because we could include them over video. I think there's enormous potential in e-health development here, but I second Nick's thoughts that we need to make sure that they're distributed evenly and perhaps prioritized to those that need it the most. I sort of try to think of the flying doctors in Australia. I spent some time there, and it's always nice to think outside the box and try and figure out how can we help these people that we just don't get to. We try to do a lot of our clinical trials advertising on Instagram and Facebook and other social media, and that also gives us a whole new breed of patients that we typically don't see. They're not the usual frequent flyers at the hospital.
Yeah. And Christiane, what is the role in your view of these digital technologies and telehealth?
I couldn't agree more with the previous speakers, but I would like to add one thing, that is that there is also the potential of reduced bureaucratic effort. We have the stuff that feels overburdened with bureaucracy, and electronic documentation simplifies work, saves time, and interconnected monitoring systems were mentioned, and that's of course important. So digitalization helps to detect risk factors early. But beyond that, also very important, I think, we can reduce mismedications. Our patients, heart failure patients, they tend to have 6, 8, 10, 12 different drugs, in particular if they are old and multimorbid, and data from the electronic patient health record can really assist automated medication checks and help medication-related risk, help doctors to become even better doctors of these multimorbid patients. And there's maybe one other aspect that we didn't mention so far, that is important for the interventional cardiologist, since minimizing exposure to radiation by using robot assistance is also a factor which should not be neglected. And doctors have only a small proportion of the radiation exposure they have had in the past from coronary interventions, when they're now assisted by a robot that helps when performing the interventions. So these are additional aspects, maybe.
Thank you. Okay, I'm going to put my esteemed colleagues on the spot. If you had a hotline to your respective health ministers in Western Europe, what would you focus on or tell them to focus on to reduce rural-urban disparities in cardiovascular disease care? I'll go to Nick first.
Thank you. Look, I think from a public health perspective, I think going back to maybe some of the answers that I've already given on multi-sectoral approaches of joining up sectors that are responsible or influential in these wider social determinants. But I would agree with the other speakers on the call of what they've talked about already, this development of telehealth and targeting those individuals which are particularly hardest to reach. But also we talked about the life course approach, and actually interventions made early in life have a much better impact than much later in life. And so actually, if we can focus in those types of areas, I would really kind of suggest that we focus on those, and recognizing that it's a long-term approach. It's not a short-term approach. Governments generally empower 4 to 5 years, have a short-term approach. We need a long-term approach that endures over a long period of time, so that it's not just changed every time a new government comes in.
Okay. Your health minister is likely to say that's not one thing. I
apologize.
Thank you, Nick. Yeah, Johan, what would you say?
So I think we need to be evidence-based here, and I also think that the greatest potential is just what Nick said, is sort of probably just outside of healthcare and trying to affect the communities in other ways. And I think that taxations and bans are probably what we've seen pretty good evidence for. So I think more than 50 countries have taxes on sugar-sweetened beverages. I think more than 70 countries have smoke-free areas outdoors. We've seen initiatives for smoke-free generations in the UK, and I think Portugal just aims to do that now. And I think there's an interesting example that I just heard about from Canada, where they've ruled that health warnings need to be printed on the individual cigarettes. And I think these are the kinds of population strategies that will take us the furthest. I don't know where the limit of that is, if sodium taxation is an option, etc. But I think we need to be more creative on that. And I agree with Nick that we need to look beyond this the next re-election to whatever parliament you're sitting in.
Thank you. And Christiane.
No, I couldn't agree more with Nick and Johan. So again, I need to find a new flavor. And one of the things I would speak to my Minister of Health is that we need to catch up with considering environmental factors that are now changing, climate, urban pollution, and we need to but from the side of the government, from employers, we have to pay attention to indoor air pollution, to noise, to the extreme temperatures that we get now with the rapid evolution of climate change, smokes, chemical, other factors that all considered to contribute significantly to the high burden of cardiovascular illnesses in Europe. And one of the points that is important, these are factors that cannot be addressed very well by the patients themselves. So they need to come from the government. They need to come from the employer. In a sense, this is in their hands to improve this, rather than that we have to have the patient as the mediator. So in addition to what Nick and Johan advise their Minister of Health, I would also ask him or her to pay attention to these factors that they have to do for us.
Christiane, that's a great place for us to end here. That what we've covered in discussing the rural and urban disparities in cardiovascular disease are complex. We don't necessarily yet have all the data that we require in a comparable way, but we do have several points in our health system where we can act, and in particular, as you've alluded to there, both social determinants, but also thinking beyond individual patients at what can be done outside of the health system, sometimes in the political context, is really important, and are, as both Johan and Nick have said, are aspects where we can have really big impact to improve cardiovascular care. I want to thank my colleagues, Professors Townsend, Sundström, and Angermann, for the discussion, and thank you to our listeners. Thank you.
Thank you.